Thank you for joining me today for this educational session. My name is Dr. Ian Thompson, and I am president of CHRISTUS Santa Rosa Medical Center Hospital. I am also responsible for cancer-related care across the many institutions that constitute the CHRISTUS Santa Rosa system. I practiced urologic oncology, the care of patients with urologic cancers, including prostate cancer, for over 30 years. Our goal today is to help you better understand how to make a very important personal health decision, whether you would like your physician to perform a prostate cancer screening blood test. This prostate cancer screening blood test, called the prostate-specific antigen, or PSA test, is controversial, and national guidelines recommend that men talk with their physicians, weigh the pros and cons of testing, incorporate their own preferences, and then make an informed decision. We've assembled this educational session to help you as you have conversations with your physician. Prostate cancer is the most common cancer in men. In recent years, with PSA blood testing, men in the United States have about a 1 in 7 lifetime risk of being diagnosed with prostate cancer. In part, this is because prostate cancer is very common in men as they age. Studies in which prostates have been examined in older men find that a 50-year-old man may have as high as a 50% risk of harboring prostate cancer, while a 70-year-old man may have as high as a 60 to 70% risk of having prostate cancer in his prostate. As many as 3/4 of all men will have cancer in their prostate during their lifetime. While prostate cancer affects most of us as we age, a man's lifetime risk from prostate cancer death is about 2 to 3%. What this means is that most prostate cancers will exist quietly, without causing symptoms or without causing a man to die from the cancer throughout the man's lifetime. A small number of these tumors will grow, spread, and cause symptoms or take a man's life. Unfortunately, as prostate cancers develop, they almost never cause symptoms. In fact, the reason why PSA testing is used, because if you wait for symptoms to develop, most men will already have spread of their cancer, a stage when the cancer is generally incurable. Now I'd like to discuss with you for a few minutes the anatomy of the prostate and how that anatomy can affect urinary and sexual function. So let's draw a picture of what the urinary channel looks like and the prostate. So the bladder sits up here where the urine is collected, and the urinary channel passes out through the penis, and the prostate sits at the base of the bladder. It encircles the urinary channel. So as urine flows, it flows through the middle of the prostate. Prostate looks almost like a donut. And as we get older, the prostate can grow, and as it does so, it can crimp on the urinary channel, leading us to, for example, need to get up at night to urinate, or the stream can slow down, and there are medications to treat that. The sphincter for urinary control sits below the prostate, down here, and that's the sphincter that if you are urinating, you need to cut off the urination consciously, you can cut it off there. But a lot of the urinary control is due to muscle in the prostate and the prostate squeezing down, if you will, on the urinary channel. The other thing that's important to consider are the erection nerves, which traverse on either side of the prostate, along the prostate down into the penis. And these are the nerves that conduct the impulses that allow a normal erection to occur. They're very important for normal erections. And the reason why this anatomy is so important is because of two things. One is that when we diagnose prostate cancer and we treat it, the treatment of that, if it causes any swelling of the prostate, it can, for example, make it more difficult to empty the urinary channel, empty the bladder. The other thing that can happen is that if we remove the prostate, for example, with surgery, because some of the urinary control is created by the prostate, it can predispose to some element of leakage of urination. The other thing is that any treatment of the prostate, because the erection nerves sit on the surface of the prostate, can affect erections, which decline as we get older, but a treatment for prostate cancer can affect the erections because of that. Before we go further, let's spend a few minutes learning how prostate cancers are detected. If a man has a PSA test value that suggests the presence of prostate cancer, the next step to either confirm cancer or to rule it out requires a prostate biopsy. Generally, prostate biopsies are performed as an outpatient. After stopping blood thinners and taking an antibiotic to reduce the risk of infection, the patient lies on his side and an ultrasound probe, shaped a bit like the physician's examining finger, is placed in the rectum. After taking pictures of the prostate and numbing the area where the biopsy will be performed, a special needle is used to remove multiple cores of tissue, narrower than the lead of a pencil, from the prostate. Usually between 10 and 12 samples are obtained. Let's take a moment and let me draw you again what that looks like. And we're going to change the orientation of the prostate just a little bit. So if you remember the original drawing that I drew for you, where you're looking at the prostate from the front, we're going to look at the prostate now from the side. Again, the bladder's up at the top, like so. The urinary channel goes through like so. The prostate sits now here. And if you can imagine that the rectum goes immediately by the prostate as such. And so the way that that is done with the ultrasound probe goes into the rectum. And this is done either in the office or in a same-day surgery center, usually with just local anesthesia. And what happens is the urologist is able to put some numbing medicine in to numb this area here. And then what occurs is that the prostate is sampled with biopsies, and the biopsies look like very, very small cores of tissue. And this is obviously much larger than the actual biopsy itself. These biopsies are maybe a little bit less than an inch long, about 2 centimeters in length. And that's how you sample to see whether prostate cancer is present. Again, it's done with some local anesthesia, so it doesn't, oftentimes people will feel some pressure. Some people may feel a little bit more pain, but because it goes through the rectum, most biopsies are done through the rectum, and there are bacteria in the rectum. That's the reason why there is a risk, small, but a meaningful risk of potentially developing an infection afterwards, and that's why we use antibiotics to reduce that risk. The total time for a biopsy is about 5 or 10 minutes. The discomfort is usually controlled with the local anesthetic, as I said, and while there's a risk of serious bleeding, and that risk is generally less than about 1%. The primary complication after a biopsy is the risk of an infection. And this can happen in spite of using prophylactic antibiotics. And it happens in perhaps 2 to 4% of patients. Some of these infections can be so significant as to require hospitalization. Now, understanding that about 2 to 3% of men would potentially benefit from PSA testing, again, that's the lifetime risk of prostate cancer death overall in the United States. Yet many men harbor prostate cancer in their prostate, and understanding what is required to determine if prostate cancer is present is a biopsy. Let's talk about how your physician may interpret your PSA test. For many years, it was thought that a PSA level above 4 was the best way to identify men at risk of prostate cancer. As a result, men with a PSA greater than 4 were recommended to have a biopsy, and those with a PSA less than 4 were recommended to simply have their PSA retested the following year. With the publication of a very large study in about 2003-2004, sponsored by the National Cancer Institute, we found that prostate cancers could actually be present at any PSA level. Importantly, however, we found that the PSA, in combination with several other risk factors, helped enormously in predicting what would happen if a man had a prostate biopsy. A critically important discovery that we made was that PSA could not only give an estimate of the risk of cancer, but also the risk of the type of cancer. In this line graph, you can see the risk of cancer as PSA increases. Even at the very lowest level of PSA, there's still a 5% risk of cancer. At a PSA level of 2, the risk of cancer exceeds 15%, and at a PSA value of 3, the risk is more than 20%. This very large clinical trial allowed us to build an online risk assessment tool that estimates an individual man's risk of 3 outcomes of biopsy. The first of these is a biopsy that shows no cancer, and that's obviously good news. A second potential outcome is a biopsy that shows a slow-growing cancer. And a third potential outcome of the biopsy is a biopsy that shows a faster-growing cancer. Before we get to some examples of how this online tool works, it's important to understand the different types of prostate cancer. If you remember something that we discussed earlier, most men have prostate cancer, but few will die from their disease. To understand this notion, it's important to know that most tumors are slow-growing. These cancers are the ones that are often present and they're silent throughout a man's lifetime. At the time of biopsy, the pathologist assigns a score to these tumors, and to help put this score in perspective, the slowest growing tumors are called Gleason 3+3 tumors. That's just a convention that's given to them. Again, the Gleason 3+3 tumors are the slowest tumors. Other tumors are faster growing and range from Gleason 3+4 tumors all the way up to Gleason 5+5 tumors. With each higher value of Gleason score, for example, 4+4 is more aggressive than 3+4, there is a greater risk that the cancer will spread and potentially cause death with time. As you can see in the figure, the Gleason 3+3 tumors are the slowest growing, and the 4+4 and higher are considered fast-growing cancers. This introduction to the different types of prostate cancer is brief, but it's important. There's also one other point that I would like to stress. In general, Gleason 3+3 tumors are slow-growing and pose a relatively low risk of spread or death. It is the higher grade, the higher Gleason score tumors that pose a man a risk. How that we know that these tumors are relatively low risk is probably best illustrated by a simple observation. In several large groups of men with these slow-growing tumors who were not treated for their tumors after they were first diagnosed, but simply followed and only treated if there was evidence that their tumor was turning into a higher risk tumor, 15 to 20 years later, only about 2 to 3% of the men died of their prostate cancer. Simply stated, these slow-growing tumors can be watched carefully and treatment avoided in most men. As you can imagine, if the long-term risk of death from prostate cancer in these slow-growing tumors is low, we really don't have any evidence at this time that treatment will reduce that risk. As a result, many, if not most men with these slow-growing tumors are simply followed carefully and no treatment given unless there is a change in the tumor that's noted with time. By comparison, faster-growing tumors have a greater risk of prostate cancer death. With long-term follow-up, even Gleason 3+4 tumors, just a notch above the 3+3 slow-growing tumors, may have as much as a 10 to 12% risk of cancer death at 15 to 20 years. If left unrecognized or untreated, the fastest growing tumors, remember those are the 4+4 and higher, may have as much as a 75% 15-year risk of death from prostate cancer. As opposed to the slower growing tumors, there are several studies that show that improvements in treatment of fast-growing tumors will reduce a man's risk of dying from prostate cancer. Now let's go back to the concept of PSA screening for prostate cancer. To review, the PSA test is used to assess a man's risk of cancer, and if it's felt to be sufficiently high, a prostate biopsy is performed. The risks of the biopsy include bleeding and infection. In general, there are 3 possible results of a biopsy. The biopsy could be negative for cancer. In this case, careful follow-up is usually recommended with another PSA test at a later date. The second outcome could be the diagnosis of a slow-growing tumor. In general, most men with this finding are currently managed with a careful follow-up program called active surveillance. Such a program involves periodic PSA testing, physical examinations, and a repeat biopsy every 1 to 2 years. The third outcome of a prostate biopsy could be the detection of a faster-growing tumor. While admittedly this is a very simplified description, many of the faster-growing tumors will pose a sufficiently high risk of spread and of complications such that treatment will generally be recommended. While there are many different prostate cancer treatments for the more aggressive forms of prostate cancer, the 2 most commonly prescribed are either surgery or radiation. These are most commonly employed due to the known long-term results of both of the treatments and the evidence that these treatments can reduce a man's risk of dying from prostate cancer. While there are many variations in each of these treatments, there are far more similarities than there are differences. The surgical procedure is called a radical prostatectomy, and it involves surgical removal of the prostate. After the prostate is removed, the urinary channel is sewn back together. The operation takes about 2 hours, and most patients will stay no more than 1 or 2 days in the hospital. After discharge, a tube called a urinary catheter is left in place for a week or so, and then it's removed. Most men will resume normal activity within 3 to 4 weeks. Radiation can be given in quite a few different manners, but all involve the treatment of the entire prostate, either with radioactive pellets called seeds that are implanted in the prostate, or with some form of radiation beam that is used to impart the radiation energy throughout the prostate gland. The treatment may range from 1 day up to 2 months, depending upon the type of treatment. Because of differences in a host of measures, there is no consensus on the best form of radiation. Similarly, with several different methods to remove the prostate, there's also no consensus that one form of surgery is superior to another. The challenges to both treatments, in addition to the risk that cancer may recur, primarily involve the risks of complications. While serious early complications may be seen during surgery or radiation treatment, the 2 greatest challenges of these forms of treatment are urinary and sexual. After surgery, urinary leakage may occur. While in most men, serious leakage generally disappears after surgery over the long term, some men may have significant urinary leakage, requiring the use of pads, diapers, or additional surgical procedures. Urinary symptoms are somewhat less common after radiation, but can include difficulty emptying the bladder, as well as development of a sudden urge to urinate, sometimes with leakage after that urgency. The other potential complication of these 2 forms of treatment involves development of erectile dysfunction. This occurs primarily because the erection nerves are located immediately adjacent to the prostate, just as I showed earlier, on the right and on the left sides. While the dose of radiation to these nerves can be modified, and while the nerves may be spared during surgery, nonetheless, sexual function is often affected by these treatments, and the magnitude of the impact on sexual function appears to be greater than the magnitude of impact of treatment on urinary function. The graph shows that the greatest impact occurs early in men after surgery, and that sexual function may improve with time. As you can see from this particular large study, sexual function prior to treatment was higher among men that opted for surgery than in men who selected radiation. After surgery, sexual function first declined significantly, but then returned somewhat. The initial magnitude of a decline in sexual function after radiation was less than with surgery in this particular study. Nevertheless, 15 years after treatment, both men who underwent surgery and those who were treated with radiation had a much lower level of sexual function than they had at the time that they were diagnosed with their prostate cancer. Nonetheless, sexual function is significantly impacted in most men. So let's now review again some key concepts related to screening for prostate cancer with a PSA blood test, as you see here. Remember, the majority of men will have prostate cancer within their prostate during their lifetime. Fortunately, most of those tumors will be small and slow-growing and will never cause any problems during a man's lifetime. About 2 to 3% of men will develop tumors that are more commonly fast-growing, that spread and will ultimately cause death from prostate cancer. To determine if cancer is present and what kind, a prostate biopsy is necessary. This is an outpatient, relatively brief procedure that has a 2 to 4% risk of a serious infection. If treatment is elected for prostate cancer, the most common treatments are surgery and radiation, and these both can have a significant impact on sexual and urinary function in some men. At this time, it may appear that the odds are stacked against PSA testing, what with the risks of serious infection with the biopsy and the urinary and sexual complications with treatment, and that most men with cancer won't need treatment because their tumors will be slow growing. However, these facts ignore the simple fact that since PSA testing began in the United States, prostate cancer deaths have fallen by about 50%. As a death from prostate cancer is something that physicians and patients strive to avoid, the question is there a better way to conduct PSA testing, trying to identify the man with the aggressive prostate cancer, and perhaps trying not to identify the man with the slow-growing cancer, the man who benefits very little by biopsy, as well as potentially identifying the man who has a low likelihood of any cancer on a biopsy? The answer is yes. We now have a method to tailor PSA testing and biopsy to a man's own individual risk of cancer. Actually, we have several methods, and all of them employ one or more tools that use a man's risk factors to estimate his cancer risk, as well as his risk of aggressive cancer. The tool we will highlight today is a tool developed based on a study of almost 19,000 men, and the study was sponsored by the National Cancer Institute. Unlike other clinical trials, the men whose experience was used to build this risk assessment tool all had a prostate biopsy, regardless of their PSA level. Now that you have a better understanding of prostate cancer, let's walk through 3 different men who are undergoing PSA testing and whose physicians are considering a prostate biopsy. The first of these is a 55-year-old man who has undergone PSA testing every year for the past 10 years. His PSA values have always been 0.2, but this year, his value increases 5-fold to 1.0. He is concerned that this 5-fold increase indicates that a prostate cancer may have developed. To estimate his risk, we will use the calculator that we developed for the prostate cancer prevention trial. This is version 2.0 of the calculator. This is the tool that was developed based on the large National Cancer Institute-sponsored clinical trial conducted in the United States. There are other tools that can estimate risk, but this is the particular tool that we will highlight for the purposes of this instructional session. This is the picture of the website your physician sees if he goes to www.myprostatecancerrisk.com. Let's now go back to our patient whose PSA has increased 5-fold from 0.2 to 1.0. If we were seeing this patient, we would want to use our tool to estimate his individualized 3 possible biopsy outcomes. The first is the risk of an aggressive cancer, and that's the cancer that we probably need to detect, as treatment may prevent death from prostate cancer. The second outcome is the risk of a slow-growing cancer, and that's again the cancer that's unlikely to spread and which we will generally simply observe. And the third possible outcome from the biopsy is the risk of no cancer being present at all. Let's enter his data, assuming that he is 55, he's Caucasian, has no family history of prostate cancer, has a normal prostate examination, and remember, his PSA is 1.0, and he's never had a prior prostate biopsy. When I push the Calculate Risk button on the website, you can now see the results. We designed this tool to display the risk using emojis because we think it helps people to understand the risk better. And again, this is based on 100 different individuals undergoing a biopsy. As you can imagine, we use a red frowny face for the risk of an aggressive cancer. In this particular case, this man's risk of an aggressive cancer is about 1%, or 1 out of 100 men undergoing a biopsy. His risk of a slow-growing cancer, a cancer that is often simply observed, is 11%. Finally, his likelihood of having a biopsy that shows no cancer at all is about 88%. In this case, our tool suggests that only about 1 man in 100, like this man, would even potentially benefit from a biopsy. Again, remember, up to 4 men in 100 may have a serious infection, and 11% of men, or 1 man in 9, would be told that they have a slow-growing cancer requiring long-term monitoring and repeated biopsies. In my own personal experience with my own patients, a man with this result generally understands that while there is a potential benefit for a very rare man like he, more people may be harmed by the side effects of the biopsy and the burden of follow-up, as the majority of the tumors that could be detected are of such slow risk. Now let's take the other side of the coin. Our next patient is a 72-year-old African-American man whose father had prostate cancer. He's concerned about his risk, and so he has a PSA test. On examination, his physician feels a hard region inside the prostate, and the PSA test is 6.5. After we put these numbers into our risk tool, we can see that this higher PSA test, combined with the other risk factors in this individual man, again remember he's African American, he has a family history of prostate cancer, he's older than the first man, and he also has an abnormal prostate examination. All of these factors work together to make his risk of aggressive cancer almost 39%. This means that almost 2 men in 5, like this man, will have a potentially life-threatening tumor. In the otherwise healthy 72-year-old man, like this gentleman, most men will request a biopsy, allowing potentially curative treatment to be initiated in those with a more aggressive form of cancer. We've now examined 2 ends of the spectrum. Let's now take a more average man that might be seen by a physician like myself. Recall that when PSA first came out, there was a general thought that anything above 4 was abnormal. While, as you now understand, this was a far too simplistic approach, let's now consider a 60-year-old Caucasian man whose PSA has always been below 4, but this year it rises to 4.1. This particular man has no other risk factors for prostate cancer. When we enter these values into the risk tool, we can see that he's between the 2 other men. His risk of aggressive cancer is 5%, and his risk of a slower growing cancer is 17%. His likelihood of a negative biopsy is about 78%. In cases like this, I have seen 2 different men with precisely the same results come to 2 different conclusions. In one man with this finding, he may say that a 5% risk of an aggressive cancer is far too high for him to wait, and despite the risks of biopsy and the risk of detection of slow-growing tumors, he may prefer to proceed with a biopsy. In another man with precisely the same cancer risk, that man may say that if 95% of the time a biopsy would either be negative or show a tumor that may not need treatment, that he would prefer to not have a biopsy and simply monitor his risk. Oftentimes, factors like risks of biopsy, risks of treatment such as sexual and urinary function, and other factors are valued differently by different patients, leading two very well-informed men to reach opposite conclusions about whether they wanted to undergo a biopsy. By this time, I'm sure you feel like you have almost too much information. While that's a normal reaction to this very complicated information, it's important for men who are considering whether they want to have a PSA test or how to interpret their PSA test to have an understanding of the complexity of PSA testing, the complexity of prostate biopsy, and of treatment. Organizations around the world have generally concluded that PSA testing should be offered to men age 50 or 55 and older, but that physicians must explain to them the risks and benefits of PSA testing before it's performed. That is the purpose of this video, and we hope that it has been useful to you. There is no one right answer for what to do in every man. In general, a man who is very concerned about his risk of prostate cancer, either because he may have had a family member with the disease or he knew a person with prostate cancer, in that particular man, he may want to consider a PSA test. He may conclude that the risks of the biopsy, the risk of detection of a slow-growing tumor, and cancers that are present and which remain silent in most men as they age, and the risk of treatment with sexual and urinary complications, are less of concern than the potential benefit of detection of a life-threatening tumor. On the other hand, some men may be more concerned about the risks of PSA testing, the biopsy, overdetection of cancer, sexual and urinary complications of treatment, and they may simply say that they want to omit the PSA blood test from their annual group of tests. Importantly, if PSA testing is performed, we strongly advocate the use of the risk assessment tool like the one we showed today to help counsel men on their individual cancer risk and to help them make an informed decision as to whether a prostate biopsy is appropriate. It is important, as you make your own decision, that you seek guidance from your physician. Your primary physician can help significantly in this process, as he or she likely best understands your own medical condition or conditions, and probably also understands, probably better than any of your other physicians, your medical preferences and how you make a decision about your health care. A urologist or a urologic oncologist may be helpful as you consider your options as well. This specialty has specific expertise in understanding prostate cancer risk and the potential risks and benefits to an individual patient. Ultimately, however, it remains your choice that should dominate the conversation. Your physicians should be used as resources to help you make that decision. Here at CHRISTUS Santa Rosa, and specifically at Medical Center, a magnet-designated hospital in San Antonio, we are committed to the highest quality of care and compassionate care for our patients with prostate cancer and for those men who are concerned about their risk of prostate cancer. We have had the privilege and responsibility of overseeing some of the most important clinical trials for this disease over the past several decades. We will continue to push forward the frontiers for prostate cancer detection and treatment as we seek the day in the future when no man loses his life to this disease, and when we test and treat only those men who will benefit from those activities. God bless you and your family. It is truly an honor to serve you and all of our patients.